Before Dr. El-Shanawi introduces our speaker, I did want to just make one announcement for those of you that are here. The Fellows Teaching Competition will be today at 4 p.m. in HSRB in the auditorium, and there's refreshments from 4 to 4:30. So for all of our fellows who are planning to compete next year, this is a good way to get a little taste of what you might consider presenting. And it's going to go through 6 p.m. And so with that, I'm going to hand it over to Dr. El-Shanawi, who's going to introduce our speaker, Dr. Adus, today.
So I am very excited and honored to introduce Ann Adus to give us a talk on fetal to neonatal care navigating the continuum, and the neonatologist perspective, which is always nice to hear. Ann is the director of neonatal simulations at CHOP. She's medical co-director for the Center of Simulation at CHOP and a professor of clinical pediatrics with a particular interest in resuscitation, fetal care, and delivery room management of patients with fetal conditions. Personally, Ann was my mentor through fellowship and during my 2 years as an attending at CHOP, and remains a mentor for me. And I would just like to point out that she is the one to blame when I'm constantly wanting to debrief about things. So I really, she's shaped who I am as a provider, and I'm really excited that she gets to share some of that with all of us today. So thank you, Ann.
Great. Thank you, Summer, and thanks to everyone else. It's exciting to be with you. I wish it was in person rather than virtually. I was kind of asked to talk today about fetal care, simulation, etc. So I've taken some liberties with what I was asked. But please feel free. I don't know how casual this usually is, but and I certainly probably will not be monitoring the chat while I'm also speaking, but if there is times where you would like me to stop and explore something, or you have questions about something I said, please feel free to stop me. I will also do my best. My mouse is being a little bit sticky right now, so if I'm a little slow in moving something, hopefully it's just because of the mouse acting up. So here we go. So the first thing that I wanted to kind of disclose, because I have no formal disclosures around this topic, but I want to acknowledge, of course, that families come in many different configurations, and other family members besides the pregnant mom is very important for the care of the fetus, the mom, and the newborn. But for the purpose of this talk, I am really going to focus on the maternal baby dyad. But again, just wanted to acknowledge that for those people who feel like I am not talking about the fathers or the other mothers, etc., children, grandparents, support, whatever it may be that makes up this family unit. And then I also, if there do happen to be any MFM, OB providers in the room, the other thing I wanted to acknowledge and clarify is that I'm going to use the term delivery room in a broad sense to encompass both the care provided to the mom during the birthing process and the stabilization of the newborn. But I want to acknowledge that strictly the delivery room is actually where the baby is delivered and includes the mom, obstetrics, and MFM teams. And at CHOP, we do mainly resuscitate in a separate room, which we frequently refer to as the delivery room, but it really is a stabilization room because it's not actually where the delivery process. But I will use those terms interchangeably for the purpose of this talk. So I hope that that doesn't offend anyone, but that's why I wanted to acknowledge it to start. And then with this, of course, in this talk, I'm hoping to really discuss how we can collaborate, coordinate, communicate a little bit better, and simulate being one of my areas of interest to mitigate the challenges that we see in caring for the fetus along this continuum to enhance the opportunities for us to optimize the care of the maternal fetal dyad, and to stimulate some ideas for how we can improve our care along this fetal neonatal journey. And of course, my next caveat is we don't have this perfect here at CHOP. We have our own challenges that allow us to have our own opportunities, ideas on how to fix them. So hopefully maybe I'll learn something from you and your teams about the way you navigate some of this that we could use here. And when I was preparing for this talk, I read this article that was published in 2014 by the group at Stanford, who also has a big program. And they wrote in their paper that the ideal of a tightly integrated multidisciplinary fetal center team engaging consistent group dialogue and data sharing across specialties, leading to implementation of a highly evolved consensus approach to prenatal consultation for complex fetal anomalies is unfortunately not necessarily a reality. And I think that's part of the reason why we're all here and listening, and this highlighted it when I was preparing for this talk again, that it's a challenge everywhere. And of course, it's not just counseling, the approach to prenatal consultation that is a challenge with us all working together. It's for the rest of the care. And I do think that there's certainly room for all of us to become more tightly integrated in our teams, to engage in more consistent group dialogue that really allows for all players in the room to speak up. So one of my goals in thinking when I was developing this talk was really to think about different frameworks that are kind of on my mind right now to help us achieve this better reality. And some examples of some things I think that we actually do pretty well at CHOP that can help with this. I'm going to start off by moving on to what are some of the inherent reasons why this is a challenge for us. And so first, I think there are structural barriers. So this could be a structural barrier such as the hospital, which maybe includes geography within your hospital or geography between hospitals when they are separated by more than a tunnel. And I think this is particularly appropriate even when patients have to travel to MRI down 4 floors and the radiologists reading the MRI aren't co-located with the obstetrician who's trying to interpret the MRI and then counsel the family around that. I think there's also organizational structure, and this study I've listed below by Ket kind of highlight this by saying that most fetal care centers are administered by MFM and OBs. And I find it interesting that wasn't even in that place really a room for co-administration. And I think this sets up a hierarchy of who actually owns the patient, who owns the space. Are we coming in as neonatologists, visitors within the space? And that already sets up having less of a seat at the table almost. And I think there's other structural things, like for us, actually, surprisingly, charting is one of those things that's a real nightmare for us because we don't officially most of us don't do a lot of outpatient. So to get us in the outpatient setting takes like 3 phone calls for us to even be able to access the note to show up in the chart. And then of course, without that note showing up in the chart, unless we've had direct communication with the MFM about this is what I talked to the family about, people don't know exactly what we've talked to the family about, and that then hinders communication and consistency, which I'll talk about more later. And so I think there's a lot of things, even just within the way we organize ourselves, that lead to challenges in us providing optimal care. The next challenge is, of course, that many of us still work in silos, and each silo represented here is a discipline. So maybe it's MFM, maybe it's neonatology, maybe it's surgery, ENT, anesthesia, genetics. And the challenges, I think, between our services also become inherent when we have different but overlapping areas of expertise. So who is really the ownership of that? When do we get involved? When is it the fetus our patient also? Or is it only become our patient when it is a newborn? How does that work for the rest of the specialties? And I think it gets even more complex for us. Like sometimes there's even different neonatal teams involved. So we have patients that go to our neurosurgical team. We have patients that go to our regular neonatology team. We have potentially different people even consulting within the SGU based on what the patient is going on with the patient. And so this just adds to the complexity. And then on that, there's also these inherent tensions that go beyond the silos that challenge our ability. And these are just a sampling of the ones that I were thinking of. Are we as neonatologists, do we believe in a generalist model where all neonatologists should be able to take care of everything that's in front of them? Or do we subscribe to subspecialist model where we have a chronic lung disease team, we have a CDH team, we have a congenital heart disease team, and it feels like we're moving that way. And I personally think that if you take it purely on what might be good for a fetus or newborn, that specializing in that and knowing what all those patients look like is a benefit, but it does get challenging when we can't support that system outside of discrete areas. And I think it sets up room for conflict of who goes to what deliveries, and are you like a selected member to go to this delivery, but you're not selected to that. And that again, it perpetuates a hierarchy that we don't want to have. And it perpetuates that some people are better than other people. I think it certainly comes up in our level 3 and level 4 units. It comes up around when patients should be transferred from the delivery room where they should go. This happens for us when we have patients deliver at our adjoining university hospital. Who should be at those deliveries? Should someone who goes to those deliveries at CHOP in our special delivery unit go to HUP to be at those deliveries at HUP to, but then again, that brings up that inherent tension of, is that neonatologist who mainly practices at HUP, are they not good enough to be at the delivery by themselves? And how can we avoid that? And then of course, I think it, as I mentioned before, it does come up somewhat in when does the fetus become our patient? What are our responsibilities to the mom and the rest of that family unit? And ACOG does have a statement that the AAP also endorses that talks about the maternal interest in general are paramount over the fetuses, and that even moms can refuse fetal interventions, even if maybe it's in the best interest. And while that seems like, okay, great, fine if mom refuses a fetal surgery, but what if she refuses a med, say, to treat the SVT, that we think is going to have little effect on her? Like, how does that balance come in? And clearly it benefits the mom, which I think is probably the right thing, but it sets up inherent tensions when we're having conversations, say, around delivery timing, et cetera. And so I think those are just important to think about. And it comes in, some families don't want a C-section, but when the baby's expected to have severe physiologic instability at birth, and especially for like a cardiac, and you don't have your cath team or your OR team readily available for a vaginal delivery that happens in the middle of the night, the family wants everything done, but they also don't want to have that C-section, have it available. That sets up intentions on how we work with our cardiology team, how we resuscitate the baby and with the family. So all of that is a lot to negotiate and think through, of course. But I think it goes, of course, that with all those challenges, then there's a lot of opportunities for us to intersect and to collaborate, to really work together to care for the mom, the fetus, and the neonate. And again, these are next I'll spend a little bit of time talking about some ideas about how to come together to think about a shared goal, a shared purpose to take the best care of them. And so right now, I don't know if anyone has read this book, The Culture Code. I started reading it, and I think there's some really fascinating ideas in it and thoughts in it. This just happened to be one of the more recent chapters I made it through. And these sections of framing, rules, rehearsal, explicit encouragement to speak up, active reflection were mentioned in chapter 14, which has a wonderful name. But basically there are things from Amy Edmondson, who is the author of The Fearless Organization and the psychological safety kind of guru. She did a study of 2 hospitals that had were learning how to adopt a new, like, minimally invasive surgical technique, some, new fancy thing. And one hospital that was a smaller hospital, less of an ivory tower hospital, even though she didn't name, which really didn't do it very well and didn't have as good outcomes. And she kind of noticed in her study about these 5 areas that I think are actually really important, and I'll touch on some of them today. But in general, it's framing. So what she noticed in the hospital that really did it successfully is that the new surgical technique was really framed as a learning experience for those team members. It wasn't just one other thing to do. And it was framed in, like, it's a learning experience for the team. It's not just for the individual surgeon who's learning this technique. It's a whole team experience. And in the roles, it was where team members were really like, you're on this team because you have these specific skills, but these specific skills also work to enhance the team. So again, it kind of gets back down to culture and to team. Rehearsal, I think, is fairly obvious. It involves doing deep dry runs, simulations to really make sure you're perfecting it before you bring it out. It's having the humility to say, like, we need to practice this before we do it. We don't have it perfect. We want to have it perfect. Explicit encouragement to speak up is fairly obvious. And then active reflection, which you'll see as I talk about later. And I think this really involves our debriefing. It involves thinking about where we have problems that are identified in our debriefing and how we respond to them. They did particularly mention video, and I will talk about video a little bit also as we move on. So it is a really interesting book. It's a fairly easy read. There's lots of other good things that came from it. Another one that I got from that is in chapter 15, which is, and this really speaks about, this is Danny Meyer, who I really know nothing about, and I've not eaten at any of his restaurants. But he's a very successful restaurateur, and he's clearly more than a restaurateur in New York. And what they talked about that was really successful when people studied what he did is he was really able to have people have a shared purpose and shared goals. And he did it by fairly simple things. And these are like these catchphrases or maxims. I'll talk a little bit more. My favorite one this day is making the charitable assumption. And I've been using that catchphrase a lot. And we'll explore that a little bit more, but here are some other things. And I just really loved when I went to his website about who he even hires. And I think that speaks a lot to, why he's successful. And, these 51 percenters. And if you think about that, like, what if we all hired people or worked with people whose core emotional skills included optimism, kindness, curiosity about learning, a high degree of empathy, self-awareness, and integrity. I think we're not quite there yet. But hopefully one day we will. But I think it's really important. And so I think it's important to think of what are our catchphrases, what are our maxims that you want to bring your groups together so that they will have shared goals, and how can we accomplish this shared knowledge? And without having it seem pretty gimmicky. Like, I know whenever CHOP identifies like, oh, these are I care values, or this is our, like, hope lives here, people like make fun of it. And it doesn't really, like, we don't feel that ownership. And I think that speaks to the culture of our organizations. And I love working at CHOP. But I think it feels like it needs to be something that resonates with everyone in the institution, and not just the people who sit in a room and develop like, oh, what's going to be our catchphrase or our little motto. And that speaks into, sorry, this is a little blurry, again, to that making the charitable assumption. And this is, I think, sometimes it's hard to see the good in everyone and to make this charitable assumption that when someone does something, that they have a reason to do it that's explainable. It's easy to fall into our silos. It's easy to be harsh, critical of other disciplines. But that's not going to serve us well as if we're really trying to work together as a team. So sorry, there's a little bit of hokey stuff in there. We'll move on a little bit and get to some more practical stuff. I just wanted to give you a quick slice of what our program is. So there's the Center for Fetal Diagnosis and Treatment, which is where families come in. That's where all their initial counseling happens. It's a group of MFM, OBs, social workers, genetics, lactation, surgery team, neonatology teams. There's also the fetal heart program, which in addition to the CFDT, which is really the maternal side of it, the fetal heart program, of course, counsels and does everything with diagnosing the fetus and counseling the families around the cardiac diagnosis. Then a certain number of families, of course, not everyone will deliver in our special delivery unit. And then for the most part, except for the rare ones who maybe stay in the SDU, either because they're an innocent bystander twin or because they're a palliative care patient, will be admitted either to our NICU or to our CICU. So I think you can already see that it's a fairly complex system that takes a lot of work to try and integrate everything together and make sure there's crosstalk for us to ensure we're providing consistency. So I thought I would just show a snapshot. I'm sorry, let me just go back. So the way I'm going to structure this next part is really thinking about the family's trajectory through our Center for Fetal Diagnosis and Therapy. I think the first visits usually do center around making sure we're understanding the diagnosis. I'm sure it's not uncommon for your teams also that a family comes in with one diagnosis and leaves after the initial counseling and imaging with another diagnosis. Perhaps it's one that hopefully is better than what was expected and doesn't need the services of the fetal care center. Perhaps it's one that's a little bit actually worse than the family expected. And then, and this also then becomes in what's the plan of care? Is fetal intervention a possibility? What else needs to be done? How often does the patient need to be followed? What are the risks? And then, of course, there's the counseling that then occurs to explain all this to the family, to work with them, to see what works with their family, their goals, their wishes for their baby and for their family, which clearly, of course, entails a lot of group conversation to coordinate across all the disciplines. But hopefully this counseling is done based on a team's recommendations. And then, of course, after that, things change. We all know that things change throughout the pregnancy. The status of the fetus changes, what we're seeing changes, the status of the mom changes, and that can lead to redoing our counseling. I think it's also along this trajectory, counseling differs. A lot of times the first counseling sessions, there was really talking about goals and decision-making for families. And the latter counseling is sometimes is more about information sharing, though not always. So more like, okay, now you're getting ready to deliver in the next 2 weeks. This is what it actually looks like. I know we probably talked about it earlier, but now this is what the delivery room looks like. Your baby's going to be taken right from you. We're going to put a breathing tube in. You might not hear your baby cry because they're going to forget that if you talk to them about it when they were remote from that delivery. So then next that gets into what some of this looks like practically. So what this looks like practically, so you can see here circled in red, there's several meetings that we have on a weekly basis. And these are meetings where that ability to do that fetal review is happening. So there's every Monday morning, there's a review of what patients are going to deliver on the unit that week. And then we have almost every Monday meeting where we specifically talk about our CDH patients, and we talk about the CDH patients that are scheduled delivery in the next 2 months, and can start talking about what we think is going on with them. It might be discussed about fetal candidacy at that time or where they are in the process. Then this is a fetal meeting that happens where all the non-cardiac patients who are coming in to visit in clinic are being reviewed, looking at imaging with the radiologist presenting the imaging with the MFMs there, the surgeons there, social work there, genetics there, et cetera, to discuss planning for the mom and where they are in their process. And then there's a separate fetal heart meeting where they go over complex new patients and talk about all the upcoming deliveries also and what's expected for them. And then there's other ad hoc meetings, such as this one that is tomorrow, where there's actually a team meeting for a mom who is planning on undergoing fetal surgery for an MMC. And that again is a group team meeting where all the team players are in the room or virtually on with the family to review what the plan is and to get consent, et cetera. And yes, I did finally make it to the dentist this morning. And I think this is really important. It's important to have these multidisciplinary meetings for multiple reasons. It's perspective taking, so we can all make sure we're seeing the same thing and thinking about the same thing for this patient. It also shows mutual respect for each other, that we can be in the room and listen to the radiologist and have their interpretation of what they're seeing, or the neonatologist and what they feel like this baby is actually going to look like in the delivery room and what we should be offering. And so hopefully, again, this can allow for some of the silos to be broken down. It's also clearly important to make sure that we're providing appropriate counseling. And, I think it's also important to think about that it does matter who counsels. We do counsel in different ways. We talk about different things. We approach things differently. This study that you see, the obstetrics one, it even talks about, and I think we know this a little bit, but if a family makes it to a fetal care center, the fetal care centers and those programs are going to counsel a little bit differently than an MFM isolated in an office who still might not see a CDH that much. And I think the study was a survey study, but asked providers in these different centers with these different affiliations, like if you had a patient with trisomy 21, or there was I think an MMC, like about recommending termination. And I think, certainly we've all seen the families who have come to us who referring people have recommended termination. We're like, yeah, we don't think you need to terminate for this. This is something that we can manage. And so I think that that's important for us to also acknowledge. So I'm going to dive a little bit more just into a couple things around counseling. I think, clearly counseling in and of itself could be its own, talk. Chosen a few that I think can really help us with some of our challenges. And I think, the first that I have here is consistency, and I think it's across disciplines. And, I think it would be overwhelming for us to all be in the room with a family trying to counsel together, to have the cardiologist, the neurologist, the nephrologist, the ENT, everyone who might need to see that patient to be in a room together would probably be overwhelming. But I do think that it's important for us to try and be consistent in our message. And I think frequently it falls on us as the neonatologist to be the coordinator of that, to talk when we're going to counsel the family, like let's talk to the neurologist to understand what they told the family, talk to the cardiologist, talk to the MFM, to try and coordinate the message so that we meet with them, that we can be consistent also in what we're saying. Or if we're not going to be 100% consistent, at least we know what they've been told and can frame it in a way that doesn't sell our colleagues, like throw our colleagues under the bus, so to speak. And I think it's also important for us to acknowledge that sometimes there is inconsistency, and that's also to be expected. And I think it happens within us. I might counsel a family, but I might not be the one at the delivery. I'm likely not to be the one at the delivery the way our schedules are. And so I have to make sure that I allow the room for my colleagues who might practice a little bit differently to do that, and let the family know, like, we all do practice a little bit differently. This is our general approach, but things might look a little bit different. Or, if I'm also counseling on what might happen in the unit, we all do things a little bit differently. We have to make sure families are aware of that, because if we don't warn them about that, then they will see our inconsistency, and that will hinder their trust in us. So it takes a lot of work for us to do fetal consults. It's reading the chart, it's trying to talk to people, it's making sure we understand. Sometimes it's a matter of just asking the family, can you, let me know what page you're on, what you remember from your previously counseling, what have you been told? And then that way you can help to clarify anything. And at least you can try and be on the same page as the other people. Or if you're going to be on a different page, you can explain why you're seeing things a little bit differently based on either new information or what your own experience. And then the next thing around counseling is uncertainty. And I love this quote. It's from two of our fellows who wrote an op-ed in academic medicine around the time of the COVID, during the COVID pandemic. And I'll just read it. It says, we can be present and vulnerable with families, navigating uncertainty and adversity, honor their honesty, resilience, and grace, and learn from them about the light of parenthood. It can remind doctors to be honest with patients about uncertainty, but celebrate love and hope when they exist. And we have a lot of uncertainty, and we need to be able to address it in our counseling. And it's hard, certainly, to do, but we have uncertainty in a diagnosis. There's always times where patients come out with a different diagnosis than what they were counseled about. So we have to be honest if there's things that we're seeing that we're not sure, like it may be this or it may not be this. In the outcomes, certainly, like our some babies do much better than they expected. Other babies don't do as well as expected. We have to be uncertain. Frequently, we say we need to meet the baby, and that's going to be, unfortunately, until we meet the baby and see how the baby responds, we might not be able to give you any more diagnostic accuracy or outcome. Which brings us to the last thing around counseling and I mentioned this because it happens to us more frequently than I would like it to, that you read someone has counseled the family, cardiologist, MFM, neurologist, and it's a really difficult, tough diagnosis, and they call you to ask you to do a consult, and they're like, the family wants to do everything. And I think most of us know that ideally we shouldn't be using that word do everything. That do everything means very different things to different people. And so, our job, of course, as neonatologist, is to piece that out. What does really do everything mean? And most of the time, for most families, it's not really do everything. It's like they want us to give the baby a chance, and that we are the ones that get to determine what's involved in that chance. So it may or may not involve providing compressions. It may or may not involve epinephrine. It's all going to be context and situation dependent, depending on what we're seeing with the newborn once it's actually born, depending on what the family's wishes and desires are. And then, of course, it's really important to make sure that we've communicated that to our colleagues and to the rest of the team what this actual do everything is. And so we have some patients certainly who are full palliative care, who are a true non-intervention. And then we have patients who are more of a trial of intervention, who then may transition to palliative care, depending on what the extent of what we've recommended for the resuscitation. And then this will bring me to the next part of our talk, which is really talking about the birth journey. And this is what happens at CHOP. We have pre-delivery planning, which I'll talk about these in a little bit more detail, ensuring the team is actually ready for the delivery before you get in the room, doing a huddle, stabilizing, which I'll talk less about right now, and then, of course, debriefing. And then this just gets into even how much busier the schedule is when we look at all these opportunities that we have. So, I already mentioned about the meetings that were circled in red. And these meetings not only are in that pre-delivery planning in terms of the counseling, ensuring we have the right diagnosis and understanding it, but they also are important for us to talk more about what that pre-delivery planning is like. The meeting circled in orange, or it's kind of more of a yellow, it looks like, are really about education. So there's every Monday morning, there's an STU education. Sometimes it's M&M, so it fits more into our debriefing. And then or I guess it's yellow. And then we have some, you'll see our Presto simulations, and I'll explain what Presto is, but certainly that can be around education as well as refining processes, et cetera. The green ones circled in green are really the ones where we review, and they're part of our debriefing program and our QI program. You can see we have we have an official SDU hypothermia project because we're noticing that our newborns tended to be, even our term newborns were being hypothermic in the delivery room. And then we did have an error, a medication error in the delivery room. So we did a root cause analysis about that. And so that again was all SDU delivery related. So there's a lot that happens. Not all these meetings clearly are every week. Some of them are, but many of them are actually every week that we're having these meetings to discuss our care, both within our own neonatology team, but most of these meetings are all multidisciplinary and interprofessional. So moving on to pre-delivery planning, and I'm happy again to answer any questions because I'm not going to get into full detail about everything, but I think this, again, it's really important for us to all be trying to communicate together. I think the timing of delivery frequently comes up, of what gestational age, should it be 34 weeks, should it be 36 weeks, should it be 32 weeks, should it be 38 weeks? And I think it's one, we're just thrilled that we're being engaged in those conversations about what gestational age is. And I think it really helps us all to get, again, to make that charitable assumption about when an obstetrician or an MFM is recommending a delivery gestational age that is earlier than what we would recommend. But I think it's important because, you know, with the uncertainty, a lot of the diagnosis we see do have an IUFD as a risk. And so what is that balance between a little bit of prematurity versus continuing the pregnancy and having the possibility for a catastrophic accident to happen? The same thing is for the type of delivery, and I have here the door represents an exit procedure. So should it be an exit procedure? Is that necessary to secure that airway? Presto for us it's not a great acronym. It's from anesthesia, and basically it means that they want to have a second anesthesia team available. So one for the mom and one for the baby. It stands for procedure requiring second team in the OR. But is it that we think the baby will have some initial stability and we have time to stabilize the baby, but we're going to be ready to have ENT secure the airway if that's needed, or we're going to be ready to do an SCT debulking or a resection of a CCAM. So having those conversations with MFM, with surgery, with ENT to help that decision making. When again, none of our prenatal imaging, it can be very suggestive, but it can't tell you 100% how that baby is going to do. So we have to live with that and you know, to the best of the team's ability, predict which one we think is the optimal one to do. And then of course the resources delivery, what team members do you need to have there? Do you need extra team members? Like, is it where you don't really need a full Presto, but maybe you want to have airway team on standby to call up if needed versus actually in the room? Or if you are doing a Presto, to make sure you have all the team members. So then it becomes the operating room airway team and nurses and scrub nurses, et cetera, and not just the OB and not just the OR team for the mom. Are there any special drugs you need to have at delivery? We were recently at a baby that had complete heart block, and you know they wanted us to have isoproterenol at the delivery. So making sure we have done all this planning ahead of time. Do we need to have a defibrillator? Is expected to be an unstable arrhythmia that we need to have everything right up and set up and make sure we have the right people who are comfortable running the defibrillator. The other thing is sometimes we have twins that have a heart defect and they're the same sex. How do we tell which one is which? So we might have to have our echocardiographers in the delivery room with us to make sure that we are doing our interventions on the right baby if it's not obvious based on their appearance. And we will always, for same-sex twins with cardiac defects, we will always, almost always have an echo, because chances are they're being a little bit preterm, and the one that doesn't have the heart defect will also be blue in a challenge. So we always try to have them available. And you need to plan this ahead of time to make sure that they are available. when we talk about ensuring readiness, so you've done all that kind of pre-delivery planning, and now you need to make sure that you also are ready. And so sometimes it involves emails to multiple people to really clarify those team members who's doing what. We frequently do this when there's also going to be general anesthesia there, like who is going to be responsible for the airway? Is it the anesthesia team or is it the neonatology team? Sometimes the degree of prematurity is what rules it, but being able to have those conversations and reach out to people ahead of time makes it much easier when then you're going in and doing your huddle. You know, again, meeting with the family for those complex deliveries, or perhaps even meeting ahead of time as a team and making sure everyone agrees, and then meeting with the family and going over again the plan with the family and what the risks and benefits are. Certainly we do just-in-time simulations for any conjoined twin delivery that's planning. We do simulations ahead of time to make sure that the team is ready. Frequently, the second we schedule the simulations, the mom delivers the next day. So we try and do this more and more in advance as possible. We might also send people the most recent guidelines to make sure they're up to date on any guideline changes that it had. Frequently, people even call us. So they, you know, if it's someone who hasn't been to delivery for a while, that person might call me or a colleague and say, hey, can you just review what we're doing for these patients right now? And so it's really nice to see that. For our younger team members who really, you know, want to be doing the right thing and are willing to ask for help. And then before every delivery, we do a huddle. We do have and I'll show you somewhat of a picture of this, but we have the ability in each of our rooms where we have a big screen and we can pull up this kind of huddle procedure, which is what this is a picture of. I think doing a huddle is really important. There's some work by this woman named Mary Waller, who's an organizational psychologist. I think she's out of Texas right now, who talks about the huddle as setting the tone. And so I think it's inviting in participation of all team members sets the tone and helps to get to that part of expecting everyone and encourage everyone to speak up. I personally, when I do a huddle, I like everyone to be around in a circle and not doing any other tasks, because the second someone starts doing other tasks like setting up the bed or drawing up vitamin K, then they're not really listening to the huddle. And it's interesting because in SIMS recently, we were doing SIMS with a new group of nurses who are orienting to the special delivery unit. And I noticed that during the sim, like we were trying to decide, you know, whether or not to intubate the baby or not in the sim. And I was really the only one talking, and clearly I had a fixation error trying to figure out. And so during the debriefing, I just asked people, I said, what can I have done to encourage other members to speak up? I felt like you probably all had good ideas or had questions about what the plan was. And they really said, to be explicit. So in the team huddle, be explicit that you expect, I will even say but you expect people to ask questions, to expect discussion, and expect people to offer their opinions. And so I think we'll probably add this to our huddle screen. This is just a picture of our screen since we talked about conjoined twins. We've of course designed this through doing simulations as well as during video review of our conjoined twins. So we can really try and specify exactly where people are. So that way in the huddle, you can pull this screen up. We also send it to people ahead of time. So hopefully you used it during the simulation, the team that was going to be in the delivery room for the conjoined twins. And then you pull it up at the time. And so you can make sure you have your equipment set up where you want it to be, and your team members set up. And it also helps remind people of how many people you need to have at a conjoined twin delivery. And I think this is going to take a little bit let me see if it'll load. Okay, there we go. So, and this is just a picture of a recent conjoined twin delivery. I think you can see, hopefully it mimics somewhat the screen that's up there in terms of in general where people are standing and around the conjoined twins in the middle of the room. And so hopefully our screens and everything can help support people during the stabilization. The other thing, of course, that's really important is to have flexibility and humility in the delivery room. and I think it kind of gets back to some of those maxims and catchphrases that I think flexibility and humility probably belong as one of our maxims or catchphrases. And I think this also gets to the Mary Waller's work, where she talks about adapting on the fly, that we need to be able to adapt on the fly. We need to be able to make sure we have a shared mental models, and to communicate around that. Frequently babies come out, we know this, and they are different than they appear. I've had multiple times where I've had to change course very last minute. So I had a baby that was that they thought had a limb body wall defect, where basically it was palliative care. They thought everything was going to be open and spilling out. I had to have the ability to talk to the family ahead of time, and while they were accepting of palliative care, they were also hopeful that things might be different. And the baby came out and was put for us to do our initial kind of wrap up, clean the baby off before we handed the baby to the family, and it just looked like a giant omphalos seal. And so we quickly decided, luckily I'd had the conversation with family. We quickly decided that we were going to bring the baby in our stabilization room and treat it as a giant omphalos seal rather than a palliative care. So you have to be ready to do that, and to start that off. I've certainly had palliative care babies that are billed as palliative care, and the kid comes out and is looks okay, but you still know the underlying diagnosis is going to be one that the baby can't survive. But I've had the families ask me, please, can you just give the baby kids? Can you make sure that the echo truly is what it said it was prenatally? And we've been willing to say, okay, yes, we'll have someone come and echo. That's what the family deserves, is for us to give them that ability. This works especially with our airway team. Having them there is great, but they also know that sometimes they're just going to be there and not need to do anything, that the baby's going to come out and the baby's going to be totally fine. We do have a 2 intubation rule in general, that once you're reaching your 2nd or 3rd intubation in the delivery room, you should be calling an airway team. So I think that gets into humility. We also recommend that people call up a second attending when they're in a difficult situation, either a code up there or something else, just to get a second opinion. And people do that frequently. And I think it is really important. The last thing before I move into, I want to make sure I talk about it. I think it's also important that we take care of each other in this. There have been certainly situations where I've had where people have had emotional trauma based on what we do in the delivery room. There's visual trauma from seeing kids with profoundly disfigured things. There's some that are burned in my memory. And so we need to remember to take care of ourselves. Our hospital has a second victim program, or caring for colleagues, where we can meet and discuss this. And that does bring us into debriefing. We do debrief after every delivery. Hopefully, this is our delivery debriefing QI sheet. Has been through multiple revisions over the now 13 years that the STU has been open. In general, though, it consists of questions that help get at facilitators and barriers. There's QI questions that we embed in, and also hopefully it serves as some reminder to do certain things like documentation, forms, etc. We also have more informal debriefs that we do. This is just an email I sent out after one of our SCT sections did a bulking, to the team who was there, to really think about these are some of the challenges we had. And sometimes it's just as simple as this. So it kind of serves as a debriefing, even though it's also a question of how do we move forward and make sure we do better for the right patient, which is really the goal of debriefing, is to improve care for the next ones you're seeing. We are lucky enough to have the STU video review. So almost all of our deliveries are video recorded. And actually, as I was going through Twitter, I found this little tweet. Andrew Petrosiniak is an ED doc who's very involved in simulation and design thinking around simulation. But I found this fascinating about that Biggie, Biggie Smalls, who was a rap star. I'm not familiar with his music. I guess there's a movie out about him. And part of what struck Dr. Petrosiniak in the movie was really about the video review, and about how Biggie apparently watched had all of his performances videotaped, and he would find the ones where either like things went well and you connected well with the audience, or things didn't go well, and figure out like what was it that didn't go well, and then look to avoid those in the future. And I think that that's a really critical thing. So this is just an example from a very complex delivery that we just had. This was actually a patient with a CDH who had undergone the fetal tracheal occlusion procedure. It was a difficult extraction of the balloon. There was some concern that the balloon wasn't actually punctured and there's still obstruction in the airway. And you can see all the team members that were here, huge number of team members. This created a lot of confusion, complication, not to air too much dirty laundry, but like anesthesia was trying an IV. There was like apparently like 5 IV attempts in 15 minutes. And then finally, the neonatologist was like, let's just put an emergency umbilical line, which went in 1 minute, of course. But it's amazing, even just from having the visual from the video, what you can learn and how we can say, of course, there's no way, even based on the way people are standing, that this is going to be an optimal team dynamic. And then that gets us to, and then there's the audio that you can hear, so you can hear everything. And it's not confusing not surprising that things don't go as well. And, when you have an anesthesia attending, a surgery attending, an ENT attending, a neonatology attending, it is not surprising that everyone has their area of expertise and everyone wants to, and everyone leads in their own, like anesthesia leads resuscitations when they are in the OR. We lead resuscitations when we're in the NICU. Surgery leads, trauma resuscitations. We all lead. And so then when we have 4 leaders in a room, it's going to be confusing, and we need to figure out a way to do that. We all feel like we should own the patient. I think the other thing we learned is about variability in practice. This is a diagram this is 5 babies with congenital diaphragmatic hernia. So each line is a baby. And you can see these are the different tasks. And you can see, one, it takes us a long time to get some basic tasks done sometimes, or to get the EKG tracing up there. And there's a lot of variability. Plus, there's a huge task load on that nurse. Like the nurse is doing all this. This is all the nurse's tasks and things to think about. So when you see this in the video and when you see it displayed, you're like, wow, we have a lot of work to do to see how we can improve this. And there's a lot of things, like maybe it's inconsistent direction. So it's not just, it's not just that the nurse doesn't know how to do something. Maybe it's because the different physicians at these 5 different deliveries all wanted things done a little bit differently. So we need to be able to figure out a way to work through this, which is of course where I think simulation comes in. And I think, simulation can have an impact. We know it's been demonstrated to have a positive impact on procedural safety at the patient level, teamwork skills and process measures. And certainly we know it's used beyond education. And I think really the ones that I want to think about the most are how it translates to improve our working relationships. So talking about it around relational coordination, psychological safety, and interprofessionalism. And we need to be deliberate about the design of our simulation activities if we want to get to these. Okay, so let me get back. Sorry. And this one is a study, and basically anything by Victoria Brazil or Eve Purdy. They're from an Australian adult hospital in the ED, but they do amazing, amazing work around these kind of non-patient outcome related aspects of simulation, which I actually think sometimes are the most important. Relational coordination is a framework that kind of looks at 3 attributes of relationships that support the highest level of coordination and performance, which is shared goals, shared knowledge, mutual respect. And then it helps with, these are the communication things that help to allow, again, for that high level of coordination and performance. And then they found, I think not surprisingly, that simulation is an enabler of mutual respect most strongly. That when people are in simulations together, what comes out of it is a mutual respect, and you can build that within your simulation. And then they certainly found that when the changes they came up with from doing the sims, the things they learned were around things that strengthen communication and relationships. And then I just put this together, what this would look like for our newborn that's coming out with a concern for airway compromise, of all these things. And if we did sim around them, then hopefully we can have more mutual respect, shared goals, shared knowledge, and know how we can contribute to that with our individual areas of expertise, and move forward with hopefully not having 3 leaders in the room. Next is interprofessionalism, which really speaks to how we work together with our nurses, our physician assistants, the social workers, et cetera. And I think it's not surprising, I'm not going to dwell on this a lot. There's that simulation is an ideal way of really getting at this. There's mutual studies, most of them in the student world, about using simulation to improve the way we work together. And this again contributes to mutual respect. It allows for more shared goals and shared knowledge if we know what skills everyone can contribute to move forward with that shared mental models. And then the last things, and I know we're getting short on time, is culture can be transmitted. And so we all have our own cultures. And I think we need to be aware of this when we're doing our simulations, that you can have positive things around culture, values and beliefs transmitted, as well as the negative ones. But I'm encouraged that a lot of things that is the positive is that we care for you as a learner, because we're taking the time to have you come to our simulation and we're investing in you. And that's part of the culture. Or that the patient is foremost, like here we are, we're all coming together because we want to improve our care for the patient. That is impacting culture. And then there's this other thing we need to watch out for in our simulation, and that's kind of what our hidden curriculum is. And this speaks to the hidden curriculum is those things that is not overtly an objective, but things that come out through it. So this article by Dr. Brazil really talks about, like, if you embed, I think she has in her as an example, like if you embed an angry male surgeon as to help force a learning objective in your simulation, that perpetuates a bias or a stereotype that surgeons are male and that they're angry. And so that is not something that we want to do, because one, not all surgeons are male, certainly, and not all surgeons are angry. So we want to be careful and really think about, when we're designing our simulation, how to do that we're not perpetuating negative hidden curriculums and biases and stereotypes. And then this talks about psychological safety and about how simulation, what you can, people bring in the psychological safety aspects that they see in their environment, with psychological safety developing an environment that allows for interpersonal risk-taking. So if people come in feeling that they don't have psychological safety in their environment, that's going to make it harder to achieve in the simulation. But if you are aware of that, then there's things you can build into your simulation that can encourage this environment of psychological safety. And in addition, if you have a simulation that really focuses on psychological safety and starts to create that psychologically safe environment, that will come out and work as a team, then works together in the clinical environment. Of course, if you have an environment within simulation that doesn't contribute to psychological safety, and people don't respect each other, and you can't pull that out, then that can also negatively affect. So I think these are all really important things to think about, but I think in general, a well-run simulation that is deliberately designed and expertly facilitated will bring out the positive aspects of culture, of interprofessionalism, and of psychological safety to improve the clinical care. This is just, I thought I would give a quick snapshot of all the simulations that we're doing. It certainly expands beyond education. We're designing a new patient tower that we're using simulation a lot in to design the delivery room spaces for that. Anytime we're doing a new procedure, so when we first started doing Fetal, there was many simulations around refining our Fetal procedure, DING was another study that we did a lot of simulation. As I said, we do just in time. Whenever there's a mom with fetal with a balloon in place, there are simulations that happen around balloon removal, emergency and non-emergent for that. And then of course we have a lot of educational simulations happening. I'm not going to focus on that. And then, so just to conclude, so again, I do think that we have a lot of opportunities and ideas of way that we can coordinate all of our care to optimize the outcomes of our pregnant patients, the fetuses and the newborns. And I think this is actually really important that it is about the patient, but it's also about our team, because if we don't have well-functioning teams that help to lead to wellness and prevent burnout, there's no way we can actually care for that patient together. So trying to be invested together and work towards that mutual respect and shared goals and shared knowledge and psychological safety will all help the team out, and that will then all help us take better care of the patients. And then I'm just going to conclude with this poem. I did watch Dickinson, the series on Apple TV, which I really appreciated. And this is one of the poems that was the basis for one of the episodes. But the way I see this is the first one is how we do our counseling, and that hopefully with our counseling, we can help families from their broken hearts. The second one, to ease one life, the aching or cool one pain, is around palliative care and doing that well. And I think that's a really important service that we provide. And then of course, the last is helping one fainting robin into his nest, is really about the successes that we have in the delivery room, those patients who do better than expected, or those patients who come out quite sick and that we make better. And that's what we all do it for all of these together. So that is it. Thank you very much for listening. I'm happy to take any questions or explain anything in more detail. I know that was kind of a quick run through of a lot of different concepts and ideas.
Anne, we had you on mute, but you missed your round of applause. So thank you so much for just an amazing, I think, overview of all the work and just how amazingly thoughtful you've been about building culture in your team. One of the questions that I have sort of goes back to your first slide, like showing that your Fetal Diagnostic Center and the Heart Center are separate programs. And I wonder if you could speak a little bit to what advice would you have to try to integrate that, and just wondering if that's a challenge for you all and how you've worked through it.
Yeah, that's a great question. I think it's less of a challenge, I would say, from the MFM fetal heart program world, because it's fairly easy. I think the fetal heart program in general, makes the recommendations based on the heart. It's a little bit easier. They certainly work with the MFMs to talk about timing of delivery, and I think that that at the fetal heart meetings, there's an MFM or an OB that goes to those meetings. So there is a lot of crosstalk there, and neonatologist also goes to those meetings. So I think that that's really helpful in kind of crossing that bridge. They are co-located. So the ultrasonographers for both teams share the space. The physicians are very close together too. And so I think that allows for a lot of people going from one to the other. There's coordinators that also communicate. So there's a fetal heart program coordinator and the CFDT program coordinators. So then there's a lot of talk on coordinating the care around that. Honestly, sometimes I think it's a little bit more challenging for us when it's come up for us as some of those complex decision-making around palliative care. So we have a fetal palliative care team that certainly meets with some of them, but sometimes it feels like it can be a little challenging. Like say a trisomy 18, they counsel, oh, your baby's gonna die or not gonna be offered surgery. But then when you talk to the family, they don't really want palliative care, even though it's kind of what has come down from the fetal heart team. And so it does involve a lot of us talking to them, well, your baby very well might not die in the delivery room. This is what we can offer and make sure we get back to the fetal team. But I think in some respects, the co-localization really helps. I think we currently have we luckily have been funded through the hospital, looking for a grant that will help, I think, with us also, because it will allow us, it's called the delivery room of the future. And so I think it will allow us to go back and work more with our fetal cardiologists to help cross those bridges. And I would say we consult less on the cardiac patients than we do on the other patients.
I did just want to mention that Dr. Ades has kindly agreed to allow us to record this, so we will be posting this on this outreach video library for those that want to come back to it.
And this is Summer. As we're developing our fetal program, can you think back historically to, when the fetal program was starting, what were some of the biggest challenges, and how do they differ from the challenges you guys are experiencing now? We need some inspiration.
Yeah, I mean, I think we still have some of the challenges. I think the challenges is, some of it is structural for us. So right now, the way we would love to say we would consult on everyone, especially everyone who's eventually going to deliver with us as neonatologists. But we don't have the bandwidth to do that. I mean, we only have 500, we have 500 deliveries a year, but that's still a lot. And right now, our person who goes to the deliveries is also the one who does the consults. And inevitably, when you have a consult scheduled, that's when that delivery happens. And then that's hard for families if they've scheduled to be with us and we have to cancel last minute. And so I think that's one of our challenges. I would love to see us get to the point where we have someone who just is on a rotation to do the counseling alone and doesn't necessarily have the other pulls of and responsibilities that would take them away. Because I think that's hard for the MFM and OB team also when we cancel last minute. And I think it gets to mutual respect and culture, et cetera. So I think we're better at it. The way we've done it is we've had select populations of patients, like we want to see every CDH. This is when we ideally should see them. Every MMC, every fetal intervention, but there's other diagnoses we should automatically be seeing also. I think the other thing that's been challenging is when we do have select teams. So when there's a patient undergoing feto, it's only like 3 neonatologists that we have and counsel moms around feto. So sometimes that's good because then we can be consistent and we're all really in the know about feto and how we counsel them. But it's also hard because we can all 3 be available. Well, we're pretty good at it, but again, it can be challenging when you have, especially for the MFM team. So this is the group that counsels perinatal nephrology patients. This is the group that counsels CDH patients. This is the group that counsels these patients, the fetal palliative care. And so when we silo ourselves, that makes it harder for the other teams to know what's the right group to be reaching out to. I think we've done pretty well with crosstalk across for like our actual deliveries. I think, there's still times where we don't always understand the gestational age timing at delivery or some other things that happen. There's sometimes certainly when we're like, oh, why is this an exit or why is this a whatever? But I think we're usually able, that just takes a conversation. Sorry, I think I froze. Am I back or?
You're here.
Anybody
I don't know
online,
what
you can
missed.
unmute if you have questions for those that are joining us virtually.
Well, thank you so much, Anne. I think it was really, really wonderful for us to hear your perspective on this and really just give us insight and like I said, inspiration for how we can continue to improve. So thank you so much for this talk. And it was great to see you.
It's very good to see you. Thank you, everyone.
Thanks so much. Take care.
Okay, bye.
Given the fact that we have a very limited ability to control the system like
Yeah.
this, because we only have 2 places where we can actually even interface and everything else happens